Whole Health is very pleased to present Jason Wenzel from Extend Pharmacy with the presentation, Cancer Care in the Community, Tips and Tricks for Frontline Pharmacists. This is the first of a series that we have lined up to inform what I would say, the generalist community pharmacy more about oncology specialty and our role as we're seeing more and more of these patients in our pharmacies, and also to make us aware of various resources and supports like the folks at Extend that we can rely on. Whole Health is an independent pharmacy banner, and we're very pleased to have Extend as one of our members. Whole Health has about 130 pharmacies in 7 provinces, coast to coast. So if you are a pharmacy anywhere from Newfoundland to British Columbia, and you're looking to hear more about Whole Health as a potential pharmacy banner for yourself, please don't hesitate to reach out. Jason, we do have registrations from coast to coast tonight, so we have folks in almost every province attending. And I'll kick it off with an introduction of my friend Jason. Jason completed his pharmacy degree at Dalhousie University and his pharmacy residency at the Ottawa Hospital. He's practiced as an inpatient medical oncology pharmacist for nearly 10 years, from 2010 to 2019, and is a board certified oncology pharmacist. He's earned a master's degree in health management in 2019. Jason is a founder and oncology pharmacist at Extend Pharmacy, Ottawa's cancer specialty pharmacy. His areas of research include integration of pharmacy learners into practice, data science, oral anti-cancer therapy education, and key performance indicators for pharmacists. He is currently involved in several CAPHO initiatives and is a regional clinical coordinator for the University of Waterloo PharmD program in Ottawa. So Jason, I will turn the presentation over to you. We're very much looking forward to it.
Excellent. Well, thank you so much, James, and to the whole health team. I really have been looking forward to the opportunity to speak to the group, and thank you very much to everybody for joining in on a Thursday evening as we're emerging from the pandemic and in the peak of summer vacation series. So I'm going to present from my screen here. So James, if you wouldn't mind just keeping an eye on anything that's coming through the chat, if that's okay with you. And I will be conscious of everybody's time. We've got kind of an hour assigned here, so I'll go through and then be pleased to kind of address any questions and things that may come up towards the end, if that works.
Yeah, Jason, I've got my eye on the chat and the Q&A, and depending on time, I think we'll probably park the questions to the end.
For sure. Yep, that sounds great. Excellent. I'll just give everybody a moment here to just have a quick look. I always like to be fully transparent around presenter disclosures. So I have received some grants and honoraria funding for independent research in a quality improvement space, particularly in different oncology education initiatives, as well as some speaker fees and consulting fees in the past, again in the oncology space. But each of these have been purely for independent research or independent projects. And I currently am a co-owner and founder at Extend Pharmacy and the vice president of the Canadian Association of Pharmacy and Oncology, CAFO. So this evening we're going to cover a lot together, and really we really welcome your honest and candid feedback at the end of this presentation. Our team has been very deeply immersed in oncology and oncology practice, and we're really beginning to notice kind of how important it is to have a good baseline understanding of a lot of oncology principles when practicing in a frontline community or retail setting. This oncology world is getting more and more complex, and as you'll see, a lot of our treatments are moving away from traditional parenteral or IV therapies given in cancer centers and moving to being given in the communities where of course pharmacists are very important frontline providers for a lot of these patients. So this, as James had said, is the first of what we hope to be a series of kind of raising awareness of different oncology topics that frontline pharmacists can address and incorporate into their practice. And we really welcome your candid feedback after this session to help us kind of guide what direction we should be going to make this a very valuable experience for everybody involved. So really 3 big objectives for this evening. And we've got them written out here, but really they're going to kind of intermingle through some of the case and the mini cases that we are going to discuss here. So really what we hope to cover tonight is to briefly review recent advancements in therapeutics and practical monitoring for key oncology practice areas. And I know myself, if I think back to when I went to pharmacy school, what we covered in the oncology courses, all of that has since changed. So there's a lot that is moving quickly in the practice of oncology. And like I said, this is things that you will likely come across at some point in your practice. Another objective that we hope to achieve here is to review and raise awareness of several common oncology medication errors. So in our practice and in my previous life in the inpatient setting, we were very kind of privy to concentrated areas of accidents or mistakes around oncology therapies. So I'll review, just using a few kind of quick and snappy cases towards the end of the presentation, just a few things that if you see these prescriptions or see these situations coming through your practice, I really want your ears to kind of perk up or to kind of have that acute awareness of what can go wrong in these certain situations. And then lastly, and I think probably most importantly here, is to kind of briefly introduce several accessible and reliable references that are readily available to pharmacists in a busy frontline practice that will help you in day-to-day work if patients present with new oncology prescriptions or if they have questions about therapies and things that they're actively taking. So so the first kind of polling question here, and this is just to help orient kind of the framework and discussion of the rest of the presentation, is really kind of what is your current primary site of practice. So inpatient oncology, ambulatory oncology focused clinic within a hospital, general focus hospital retail, frontline community, specialty, or other.
So I've got the poll there running. Folks, take a moment and enter a response if you don't mind. Okay, so we're at 80% have responded. So
perfect.
I'll end the poll and share the results.
Perfect. Excellent. So this is perfect. So this is kind of the ideal audience. It would be interesting to know if someone could type in the chat just what the other practice site is, just so we can make sure our next practice or our next presentations are broadly applicable as well. But this is the perfect audience for who this presentation is geared towards. So thank you all for joining. Perfect. So really the goals of, the goals of this evening are to kind of get us collectively thinking about what our practices look like, what oncology patients in our practices look like. And we're going to go through 4 sort of mini scenarios or mini cases. And the first 3 are designed to kind of meet the objectives that I had just stated, but also really to kind of raise this awareness, how you would approach these situations and kind of what type of references may be available to you. So the first scenario kind of deals with identifying and triaging toxicities. Again, pharmacists are front and center and often the first person to that the patient reaches out to when things start to go wrong with treatments. Scenario 2 is an approach to dispensing kind of a new or unfamiliar targeted therapy. And again, these can very readily come across your pharmacy, things you haven't seen before. The pace of oncology therapeutics is evolving drastically. Scenario 3 helps to kind of deal a bit with patient perception of biosimilars. So you've undoubtedly probably begun to see biosimilars, especially in a GCF space, kind of becoming a bit more common and prevalent in your practice. And then we'll conclude with a few kind of just quick and snappies. Again, these are the ones that if you see these prescriptions, to just kind of have the attention perk up a little bit, because there's potential errors can easily happen with these prescriptions. And then to just very much conclude with kind of Cancer Care Ontario's recommendations around best practice for dispensing take-home cancer drugs. And I didn't mention at the beginning, I apologize, but my practice site is Ontario. My entire oncology career has been in Ontario, so I'm most familiar kind of with the oncology landscape in Ontario and the funding landscape in Ontario. So there will be that type of a skew to it. But with that being said, I've been fortunate enough to kind of be aware of some of the practices across the country. And one last kind of disclosure here, if you join this session hoping to have a very deep therapeutic knowledge at the end, I apologize, that's not what you're going to get out of this. This will be a series of shallow dives that I hope will be broadly applicable and really kind of represents the tip of the iceberg to hopefully get you thinking about how to really optimize the care of your oncology patients in your practice. So you may be asking, why frontline pharmacists and why now? So believe it or not, I know this is a hard number to kind of digest, but 1 in 2 Canadians, based on Canadian cancer statistics, will have a diagnosis of cancer at some point in their lifetime, and 1 in 4 of us will pass away from cancer or a cancer-related complication. And it's estimated at the present time, about 50% of pipeline oncology therapeutics are oral or take-home cancer drugs. And this is because of the rapid pace of change and the rapid advancements in therapeutic that's happening in oncology practice. And we're seeing, this intense evolution of the ability to identify molecular targets that are unique to cancer tissues, and unique to individual types of cancer, unique to, transformed pathways within a malignant cell, as well as genetic components that are now very viable targets for targeted therapies that we're seeing. And this is really a space that moves very quickly in oncology practice. You see kind of first and second and third and sometimes 4th generation molecules targeting very specific receptors that are identified in different types of cancer. And there is an improved quality and quantity of life in cancer care present in a lot of malignancies, things like prostate cancer, certain types of breast cancer, certain hematological malignancies can actually now be considered chronic diseases. So we see patients living longer on therapies, but also, of course, growing older, and coming with that age comes other comorbidities and other drivers to frontline and community healthcare needs. And as you can imagine, you've seen this in your practice, a lot of these emerging oncology therapies are very complex. They may have complex regimens. They may have specialized monitoring. There may be a lot of interactions. So most of these oral take-home cancer drugs are, in the bread and butter space for pharmacists because of interactions, because of QT prolongation, things like that. There's unique side effects, which we'll touch a bit on. And then anyone who's worked in this space or deals with this on a daily basis begins to recognize that the reimbursement of these molecules is becoming increasingly complex, and although that does vary significantly across the province. But the main takeaway here is that these changes are quickly coming, they're here now, and pharmacists are really in a position, the most accessible, trusted health provider and medication expert, so that we're often the ones that patients come to first, whether really we're ready for their questions or not. So this is just, James had introduced our pharmacy, and I did just want to share a little bit about our extended pharmacy team. I'm blessed every day to work with an amazing group of pharmacists here in what we think is quite a unique and innovative practice. Again, we are very proud Whole Health partner members, so if anybody out there in the Whole Health team wants to reach out, connect with us on different projects, or have recommendations on how we can better support your practice in the cancer space, we of course welcome that. So we're a new practice, started in November of 2019, and we are intentionally difficult to find. So we are on the third story of an interdisciplinary medical building, and our practice model is a little bit different than most pharmacies. We don't have a front store or a self-select section, and we kind of see patients mostly on a referral, consultation, dispensing, and then clinical monitoring basis, and follow their cancer care longitudinally within the community. And our entire vision is to enhance the cancer medication experience for lives affected by cancer. And that's, of course, lives of the patient, but lives of the support, family members, and other health professionals that are involved in the care of that patient. So who we are is we are a team of passionate Ottawa-based pharmacists. I'm very lucky every day to work with the colleagues that I have. We have collectively 50 plus years of cancer-focused practice and experience across the full spectrum of oncology care. So medical oncology, hematology, transplant care, and gynecological malignancies as well. So we developed this practice really to kind of address a local care gap and supplement the existing scope that we foresee being important in a frontline setting for specialized pharmacists in cancer care. We're very proud to be agnostic to any individual manufacturer, brand, drug plan, or supply chain, and I recognize that is a challenging thing to do in kind of the complex landscape that we're all practicing in. We opened in November 2019 and proudly joined the Whole Health team in March of this year. So some of the gaps that we had kind of set this practice up to hopefully begin to be able to address are really some of these gaps that we've seen in patients' care across transitions within the healthcare system. And we look at these three bubbles, we all see a very important need for pharmacists in each of these respective spaces. So a lot of times, depending on where you practice, your main city's cancer center will likely have pharmacists involved in the ambulatory or hospital space who may see patients, do counseling, do interaction checks, may or may not follow up with the patient in a no-patient setting, but they're very focused on the cancer care of that patient. Now we move to kind of the frontline independent or retail space, and this is, of course, where the pharmacist knows the patient, maybe a bit less about the cancer, but knows the patient, knows their history, knows their collateral medication, and of course that's an extremely important piece of information to the puzzle of this patient's care. And then many of the treatments now we're seeing are dispensed through specialty pharmacies that may be affiliated with patient support programs or copay assistance programs. So in this kind of landscape, we've designed our practice to sort of optimize all aspects of each of these respective players and focus purely on the oncology care of patients. So we don't do any specific dispensing for diabetes, for hypertension, for infections and things. It's really oncology and supportive care. So when we think of our patient's cancer care journey, we often can think of it in this sort of simplistic model where the patient is seen and has an ambulatory oncology care team, an oncologist, maybe a nurse, and within that kind of spectrum of their care, they have family and support members, they have a pharmacy that they're receiving their prescriptions from, they have insurance providers that may or may not be assisting with the coverage of their medications, and of course there's other health providers involved in that cancer patient's care. But in reality, when you think about how complex some of this journey can be for a patient, there's a lot of intricacies, and there's a lot of people that are involved, and there's a lot of areas where communication can break down or misinformation can be given, and it really, really is a complex time in a patient's life. And I kind of put this diagram up here just to kind of, just begin to think about how complex some of the care is. And again, this varies from province to province, but what's really important, I think, as a takeaway for us as a frontline pharmacist is to kind of think of some of what maybe the patient has been through when they are coming up to see us or coming to our counters, and help to kind of put things a little bit into perspective as to why they may have some questions about their treatments, or why they may not be completely clear as to what their medications and things might be. So the focus and direction for the rest of the talk is going to be really on practical tips. I hope each of you after this evening, again, you will not be an oncology specialist, but you will hopefully walk away with something that will be helpful to your practice. And again, we're focusing on frontline practice here because we are the most accessible and trusted and, in my biased opinion, essential healthcare providers for the public. Often the first points of contact for our patients, and again, the aptly perceived medication experts. If we don't know the answer to something, if the situation and time permits, we're usually able, of course, to find a good answer to our patients. And this is really one of the big reasons why we've enjoyed working with Whole Health so far, is just this spirit of independent pharmacies and this push towards delivering excellent care to their patients. So for the rest of the session, I really want to promote knowledge translation of available resources, identify potential areas of errors, and again, I recognize that this is a topical presentation across the country, which is great, but every practice site from province to province, from city to city, from site to site is going to be varied. And again, if you guys have questions, please feel free to fire them in the chat and we'll answer them. If not today, I'll reach out to you afterwards and be pleased to answer them. So the first little case we're going to talk about here really evolves around these recent advancements in therapeutic and practical monitoring, and tying that into really triaging toxicities for your patient. Remember, you're going to be often the first person that this patient comes up with this potentially odd toxicity or this potentially severe toxicity that you may or may not be familiar with. And before doing that, I think of anti-cancer therapy or treatments to fight cancer really in three big buckets. So the first bucket is cytotoxic therapy. And unless you're a relatively recent grad, when you went through pharmacy school, this is probably what you learned about, cytotoxic therapy. This is tried and tested, but it's old, it's dirty. I tend to think of cytotoxic chemotherapy almost as the TCA of cancer treatments or the tricyclic antidepressants. We know they work, but we know they're really dirty and they affect a whole bunch of different things. So cytotoxic therapy blasts cancer cells, but of course it also blasts the body's normal good cells. And this is where you see kind of the non-selective toxicities that cytotoxic therapy generates. And when we think in our day-to-day practice, we often see things like etoposide or methotrexate or capecitabine or mercaptopurine, things like that, okay? So this is, what I consider to be relatively stupid chemotherapy in that it is non-selective. It is inexpensive, but it's non-selective and it just blasts everything and kind of causes these myelosuppressive toxicities, hair loss, nausea and vomiting, these traditional things that people think about when they think of chemotherapy. Okay. Now there won't be a lot of focus here because when we recognize where contemporary cancer care is going, it's not usually new developments in cytotoxic therapy. It's developments in targeted therapy, and then the third bucket, which is immunotherapy or immuno-oncology. Okay, so targeted therapy, as the name implies, is a bit smarter. We're hitting or shooting for a specific target in the cancer process. Now, this could be a transmembrane protein. This could be a mutated kinase. This could be a specific kind of genetic marker. This could be anything that is targeted and differentiates a cancer cell, ideally, from a non-cancer cell. Now, that being said, these things are not void of side effects. There are, of course, side effects, but at least the mechanism is a bit smarter in trying to target individual cancers. And when we think of what kind of treatments exist in this space, there's really two kind of sub-buckets. One is antibodies, and we think of things like cetuximab or rituximab and things like that. Rituxan, sorry. And these are large molecules that are administered parentally. And again, in most frontline practices, we don't see antibody dispensing. Okay. The other one is the small molecule inhibitors or the tyrosine kinase inhibitors. And this is an area of rapid growth, rapid development, and rapid therapeutic increase in cancer practice. And we're seeing these types of molecules publicly funded, privately funded, and you've probably seen several examples of these, things like osimertinib or sunitinib or palbociclib, these type of medications in your pharmacy practice. The next bucket is immune therapy. And an immune therapy really consists of virus-based or immune checkpoint inhibitors. Now, we won't talk about virus-based because clinically there's not much outside of clinical trials that exists and is available to the public at this point. But these checkpoint inhibitors, you may hear called immune checkpoint inhibitors or immuno-oncology. These are the newest kids on the block, and these have really begun to revolutionize contemporary cancer treatment. And why it's important to be familiar, at least with the concept here, is because these fundamentally treat cancer in a different way than cytotoxic and targeted therapy. These are using your own immune system and basically boosting your own immune system to be able to fight against cancer. So unlike cytotoxic therapy that blasts every cell and causes neutropenia, or unlike targeted therapy that has very class-specific side effects, this immune therapy is increasing the body's ability to basically ramp up the immune system and causes potentially a lot of autoimmune toxicities. And we'll touch on a case with this in a little bit. So the first patient scenario we have, Mr. JD, a lovely gentleman in the outpatient GI aisle of your pharmacy, and asks you for help in selecting an antidiarrheal medication. Discloses that he's having an average of 3 to 4 loose stools per day for the last week, and attributes this to the new cancer treatment that he started. If you look at his pharmacy profile, no known allergies, a couple of kind of common conditions, hypertension, dyslipidemia, prediabetes, and a recent diagnosis of non-small cell lung cancer. The drug list is here that you see, pretty standard medications, and has had a recently prescribed course of amoxiclav. So the question that we have here is what is your recommendation at this point?
So I put up the poll, everyone, if you could please respond what you think is the most appropriate.
We have appropriate management, including diet and fluid intake, kind of offering loperamide at the standard recommended dose, refer the patient to the physician or the ER because of concerns of C. diff, or need more information to make a recommendation.
All right, I'm going to share the results here.
Perfect. Good. So there's no wrong answers here, okay? These cases are, intentionally designed to deal with the gray areas that we face in frontline practice. Okay? So a component of any of these is potentially correct, and need more information to make a recommendation. This is unfortunately often kind of the question that a lot of us are faced with addressing. Okay, good. So the missing pieces of this puzzle are really, how do you know this patient's cancer type? Often we're left with asking the patient. Does your plan change in this case, knowing that this patient just started pembrolizumab 3 weeks ago for non-small cell lung cancer? And if you're asking yourself, what is pembrolizumab or trade name Keytruda? Don't worry about it. That's where we're going next. No worries. How is this information relayed to you in your practice? And how is this oncology knowledge translated to and from the community, really to kind of the oncologist's practice? And again, everyone is going to have a different answer here. There's no unified answer. So the takeaway really from this case is to introduce this immunotherapy concept. Okay, this again is one of the 3 buckets of cancer treatment. This is the newest bucket, and it is kind of representing a paradigm shift in contemporary oncology practice. A lot of cancers now use this type of treatment in a first or second line setting. So there's certain types of lung cancer, certain types of kidney cancer, certain type of hematological malignancy, certain types of bladder cancers are all using this in a first or second line setting. And many other clinical trials are using this. So it's not dispensed in most frontline pharmacies, and there is often differences in public versus private administration. So we're seeing this is a space where we see a lot of infusion clinics for non-publicly funded indications for these drugs. But the important takeaway is that this is a fundamentally different toxicity than anything we've seen in cancer treatment before. And what this picture on the side is showing is kind of the relationship that normally exists between a tumor cell and a T cell. So our bodies have, evolved this innate ability to fight off early stage cancer cells or the tumor cells. And if you look at this picture here, we have these markers called PDL1, which stands for Program Death Ligand 1. And what certain tumor cells are able to do is, using these ligands, interact with the body's normal host immune system, so T cells, dendritic cells, and basically put them to sleep. It kind of outsmarts your immune system. So the evolution of a tumor cell to have these type of markers puts the immune system to sleep and allows the tumor cell to grow and proliferate. So what these class of drugs, and don't worry too much about the specific markers they're affecting, whether it's CTLA4 or PD1 or PDL1. There's therapeutic targets across each of these specific molecules, but the net effect is all the same. They're blocking these interactions that's dampened down the immune system, and the net effect is that the immune system is ramped back up, is able to basically outnumber and fight this tumor cell, kill this tumor cell, but now you have a raging immune system that is really has potential to go off the rails and really cause autoimmune type toxicities. So whenever you have somebody with a new worsening diarrhea who happens to be on a immunotherapy, and the most kind of common names of these medications you'll see will be pembrolizumab, nivolumab, ipilimumab. These others, are emerging, but aren't yet quite as common as these three. If patients are on, immunotherapy, or they tell you they're on chemo, ask them if they know, what type of chemotherapy or what the name of the chemotherapy is, because if they have diarrhea on these treatments, it could be very severe. It could be an autoimmune toxicity, essentially like a colitis or an autoimmune diarrhea. So as an extension to this case, Mr. JD calls a few days later to thank you for the recommendation. So whichever of those you chose, it worked. Congratulations. His diarrhea is now controlled without needing to go to the ER. So he reports feeling overall quite well, but has noticed over the last little bit, his blood pressure has been in the 100 over 105s. You ask him to increase his hydration because of recent diarrhea and hold one of his antihypertensives. 2 days later, he comes back to see you looking pale, repeats the blood pressure on your machine, and you see that he's markedly hypotensive. So what's actually happening here? And the main takeaway I want you guys to remember, again, we're still speaking about this new bucket of immunotherapy toxicities, is that I like to think of this as saying any itis, so any type of inflammation can happen on these treatments, okay? We're giving these treatments that are ramping up immune systems, and over time, it won't be like a light switch, but it can be within a first cycle that somebody receives. You have the risk of any itis, any type of inflammation happening. And when we think of practically what that means, it could be dermatitis, so skin rash and reactions. It can be hepatitis, so elevated LFTs, visible jaundice, things like that. It can be colitis, so we see diarrhea through stool, or it can be this really odd, interesting toxicities that affects the endocrine system. So it can be hypophysitis in the pituitary, or it can lead to any different type of endocrinopathy, so actually inducing type 1 diabetes through pancreatic toxicity, actually inducing an adrenal crisis like we have in this case here, where the patient isn't making the right hormones because of inflammation of the adrenals and things like that. So again, in a frontline position, it's tough to know exactly what's going on, other than being aware that if somebody is on this type of medication, a whole bunch of weird and wacky stuff can happen to them. And really, where do you go to kind of begin to start triaging these type of toxicities in an immuno-oncology patient? So there's a few very good references. And if you remember kind of Nothing else from this section. Just know that Cancer Care Ontario has a very good immunotherapy toolkit. So there's the website here. This is free, this is Googleable, and there's a little picture here off to the side. Again, the purpose of today is to not go through the specific therapeutics, but to recognize that this tool is available. And it actually is available for kind of 11 or 12 of the most common side effects of immunotherapy. And what it quickly allows you to do is to look at this and say, okay, the grade of the symptoms that this patient is describing to me is this is what's happening, and not pictured here is kind of exactly what you need to do. So usually grade 1, sometimes grade 2 toxicities have some non-pharmacological or OTC-based recommendations, so you'd be able to recommend those. Or if you see grade 2, 3, or 4, depending on the toxicity, it may say, refer to emerge immediately. Okay, so if you're not familiar with the grading, a good place to look here is called the CTCAE grading criteria. Okay, so again, I don't expect anyone to take away the details here other than knowing that if you have a patient who says they're on immunotherapy, if you ask them the name of the medication, you look it up and it is an immuno-oncology drug, then there's a lot of unusual side effects that could happen. And it's not because their immune system is being wiped out by cancer treatment. It's because their immune system is being ramped up from cancer treatment and they're at risk of autoimmune diseases. Okay. In the interest of time, I'll leave it at that one. Welcome to discuss afterwards if anyone has any questions. So the next case is really to kind of introduce several accessible and reliable references that you can use to help answer day-to-day oncology medication questions that arise in your practice. And this is kind of around targeted therapies. And again, we had mentioned earlier that these are becoming increasingly common. Rapid clinical pace, and these are a diverse set of medications. So here in this table are some of the more common classes that you may have come across in your practice. A lot of these, again speaking to Ontario, are going to be publicly funded. So we see a lot of these medications readily available after often EAP, exceptional access coverage, is in place, and patients reserve the right, of course, to choose which pharmacy they receive these medications from. So hopefully as you look down this list, you see a few things that you are familiar with, and things like prostate cancer drugs like abiraterone or enzalutamide, or certain lung cancer drugs like osimertinib, or even kidney cancer drugs like sunitinib. These are all quite common medications that it would not be unusual to see a patient on in an advanced cancer setting. So the key takeaway from this is that just like when we think of beta blockers having a class effect, or we think of statins having a class effect, a lot of these targeted therapies also have a class effect. Okay, so it's impossible to remember everything about all of these, especially when you only see them once in a while. But remember that they do have a class effect. So for instance, when I see an EGFR inhibitor, I'm thinking the name EGFR stands for epithelial growth factor receptor. And you think of where those receptors are located. It's usually on the skin and the mucosa. So what happens with these drugs? We have rash, we have diarrhea, we have mucositis. It's generally a class effect. Now there is subtleties, of course, between them, but as a class effect and as remembering a few things, each of these targeted therapies kind of have their own notorious toxicities. Okay. So in the second scenario, you have a lovely patient, Mrs. DH. You've known this patient for years. She presents to your pharmacy and explains she has just received a diagnosis of recurrent breast cancer that has now metastasized to her liver. You know this patient well. You've been practicing for years, like James and I. So 10 years ago, she had surgery, she had chemotherapy, had anastrozole, and today she comes to you with a prescription for palbociclib 100 milligrams PO daily times 21 days. Now, this is a treatment that you haven't seen before. So this could be palbociclib, but this could also be, insert 20 different medications that have come out in the last 5 or so years. Okay, so how do you approach this? What do you do now? Okay, and really the point of this is to kind of help provide a little bit of direction into how to brush up quickly on a cancer type and the individual treatment that you may see in front of you. So I've included this. Again, this is just a quick look This comes from CADIT's kind of pipeline listing, and this represents 2 of 5 active pages of emerging treatments in breast cancer. So you can see right off the bat, this changes fast. There's a ton of drugs in the pipeline, IV, oral drugs. So staying on top of this is a very challenging thing to do. So we have to have some type of a strategy that when these medications come to us, we know very quickly how to get some topical information to the patient to make sure that they're going to start this treatment safely. So the drug that was in this example, palbociclib, has 2 other cousin medications essentially that are in the same family. So ribociclib and abemaciclib. So these are called CDK or cyclin-dependent kinase 4/6 inhibitors. And these are relatively new therapies, and why I'm singling them out is because they are quite common therapies that are available both through public and private funding, but are also going to be very common if you haven't already started seeing them in your practice. So where these are indicated is in ER or estrogen receptor positive breast cancers, which are about 65% of breast cancers, in patients who have locally advanced or metastatic disease. So again, this is not a small number of patients given how common breast cancer is, and again, how breast cancer is becoming a chronic disease. People are living longer because of therapies like this. These are new treatments, very effective, and how they work is we're looking at the cell cycle. I know everyone on this call is having a flashback to biochemistry lessons in pharmacy class, but G1 is kind of the initial growth phase of the cell cycle, getting the cell ready to split. Synthesis is making the new DNA, getting ready for split. G2 is making the rest of the enzymes, and then mitosis, of course, is the split from one parent into 2 daughter cells. So these drugs are effective in kind of inducing what's called cell cycle arrest, or blocking this kind of conversion and perpetuation of the cell cycle. Okay, so they work very well and are found in a high proportion in ER positive based cancers. And this is why we've seen them so far kind of revolutionize the treatment of ER positive metastatic breast cancer. And there's actually new evidence coming out that's having them being used in an earlier setting, so we may begin to see them even more. So just very quickly, it wouldn't be a pharmacist talk without some type of reference to Kinetics Administration. And again, we've got 3 main drugs here, palbociclib, ribociclib, and abemaciclib. And you may begin, if you haven't already, to see some of these in your practice. Okay, all 3 of them have subtle differences, subtle trial differences in progression-free and overall survival. We won't touch on that for today, but what are some of the key takeaways? So in Ontario, abemaciclib, or Verzenio at the bottom, is not yet publicly funded. So you may not see that one just yet. The top 2, palbo and ribo, are cyclical. They are given for 21 days and then 7 days off. And you may say to yourself, well, that's kind of weird. They're not cytotoxic per se, but how these drugs work, because they slow down the cell cycle, they cause quite a bit of neutropenia. So your patient may actually have those counts go down despite this medication not being explicitly cytotoxic. Okay, so recognizing kind of the cyclical effect of these is quite important. These are drugs, again, I've got a grapefruit. I don't need to explain to a pharmacist, what a picture of an X through a grapefruit means. Okay, all 3 of these medications, again, are highly susceptible to 3A4 interactions, and ribociclib itself is one of the drugs that needs to be monitored very closely for QT prolongation, usually at the beginning of treatment, middle, day 14 of cycle 1, and then at the end of cycle 1. So again, this slide is here to show you that if you start to see these are effective medications, but they are also, potentially dangerous medications with a few interactions, and to have a look at the monograph. For the interest of time, I'll skip this slide. So what do you do? What do you actually do, or where do you go to kind of quickly find information that you need? And this is recognizing that the phone is ringing, that there are people that need your help elsewhere, and now you have a very challenging situation in front of you. Okay, so the first place I think to go by the time drugs come to frontline pharmacies or are funded in a setting that frontline pharmacies can usually dispense them, Cancer Care Ontario and BC Cancer usually have readily available monographs that you can use. Okay, these are good because they're often multilingual, and I think CCO does a very good job of telling you what side effects are going to happen, what the likelihood is, and importantly, the time frame as well. So if a patient presents to you, 3 months into a treatment and they have a side effect that's supposed to happen on week 1, it helps add a little bit of piece to the puzzle there. Okay. In addition, this oral chemotherapy education website, and just Google oral chemotherapy education is the first thing that comes up, is a very good patient-focused, professional-focused website that offers really good checklists if you ever need to counsel on one of these medications that you're less familiar with. Step by step, has little tick boxes and everything right beside it. So it's a very good reference. And again, it's American-based, but it's completely free. Now, what if someone asks you about risk factors? I don't have a solution if they ask you about something Dr. Oz says, but if they ask you something about, risk factors or prevention or something like that, really the Canadian Cancer Society is a very good spot that details different types of cancer and has clear sections about clear risk factors and different challenges that patients may ask you about. And this last section is either for your own personal reference or if you're comfortable sharing this with patients. This is the website where the 2 pictures off to the side of this slide have come from, this UK Cancer Research website. It is by far, I think, one of the most patient-friendly and non-oncology specialist friendly ways to see, what a stage 2 breast cancer looks like, or what a stage 1 colon cancer looks like in kind of cartoon pictures like this. So even for your own understanding, this is a very good website, again, free, to be able to see some of these cancer types that if you do see kind of the staging ever written in a note or anything like that. Cancer Care Ontario also has very, very good guidelines around specific symptoms that patients may experience. So if you have a patient coming in saying, I have nausea, I have diarrhea, I have mucositis, these are very good quick places to look. So you can just Google Cancer Care Ontario patient symptom management, and these come up. There's about 20 different things, anything from fatigue to sore mouth, neutropenia. They're all very clearly written out in patient-friendly language, and it's a wonderful thing to be able to go through with the patient and even just quickly refresh yourself on what's available. As well, they have patient-friendly handouts on Cancer Care Ontario for a whole bunch of different symptoms and very clear non-pharmacological interventions that you can help walk your patients through. So I see up at the top here that the chat has a few things in it, so this is great. If you guys have any other references that you've come across that you find are helpful, again, this is not an exhaustive list, but please feel free to put them in the chat and we can include them in any future presentations. So this next scenario is Mrs. T.Y. And I will disclose, James had asked me earlier, all of these are in my own handwriting. These are completely fake prescriptions, so don't worry, they're not real. We're not hiding anything or showing anything confidential here. So Mrs. T.Y. is a patient that you know well, and she presents to your pharmacy with the accompanying prescription here. So she states that she just spent 3 days in the hospital with a fever and infection a week after her most recent docetaxel-based chemotherapy. She has public coverage in Ontario, which we all know who practice in Ontario means that you can have GCSFs, filgrastim or pegfilgrastim as a general benefit. And before leaving, she opens the prescription bag, recognizes that the medication that you've just dispensed her is different than what she saw or what she received in the hospital. And the question that she has is, why is this different, and how do you respond as the dispensing pharmacist? So this is a multiple choice question. So you say, don't worry, this is Biosimilar. It's the same medication you had before, just a different company makes it. Just think of this as a generic medication, and this is what the province will cover. You could say, this is the only brand we have, so if you want it today, this is what you get. You could say, different companies make these medications. So it may look different, but it's okay as all of them work similarly well. Or you could insert a more depth to your own kind of description of a biosimilar here.
So I'll give it just a few more seconds for folks to answer the poll. You're taking a little more time this time, Jason. It must be tricky.
It's tricky. There's no right or wrong answers here. Oh, there is one wrong answer, guys. Yeah, that's good. Nobody's picked the wrong answer. That's okay. That's perfect. So I know I can't see everybody, but I would be really interested to know who has already worked with biosimilars in their practice. And I think most likely it would be in the GCSF space. Now, when we talk about oncology supportive care medications, this is a great spot for GCSF and a great spot for frontline pharmacists. In treatment of cancer, we're actually now seeing biosimilars for things like trastuzumab and cetuximab and things too, so it's in the treatment space as well. So there's no wrong answer here, and the point of this question is to really kind of recognize that although us as pharmacists, we've probably heard about biosimilars for the last 2, 3, 4 years, probably have relationships with representatives or industry partners who have products in this area. But this is still quite new to patients and still quite new to the public. And even Canada, as a national healthcare system, we're behind the game in biosimilars. So biosimilars have been readily available in the EU and in the US as an important means of cost savings for at least the last decade. So we're kind of catching up in that space. So all of that to say is that the public, even based on some of these surveys, aren't familiar with biosimilars. So try not to take that for granted when dispensing these medications. I'll leave it at that for now. We are going to have a focused presentation on biosimilar administration and funding and things like that coming up in the 3rd series of the webinar with Megan. And included here is just kind of a bit of a checklist that you can go through with your patient if time permits, if they have specific questions about, what is a biosimilar. One of the perceptions is that it's a less effective, cheaper alternative, when really every clinical inclination so far suggests it is a less expensive alternative, but it is equivalent in efficacy. So this is good. I'm watching the clock tick down beside me, so we'll go through kind of the last little section here. I can also see James is sweating a little bit, so I know he's keeping an eye on the time here for us. But the last little bit here is a Friday shift. So this is a few spots where my team and I have recognized a lot of mistakes potentially being made. And again, these are not always mistakes being made by pharmacists. We often have to play the hand that we're dealt. We know, we get all of these prescriptions that come in that might be ambiguous, that might be unclear, that might be wrong, and you're often left to fix those problems as the last line of defense before getting to the patient. And that's a challenging thing to do if you don't have all the pieces of the puzzle. So this is a few common errors. And again, I can't see you, unfortunately, but I hope you're familiar with some of these, or at least if not, you'll be familiar at the end of this presentation. And of course, this is going to happen on a Friday because this always happens on a Friday. So the first prescription here is for tacrolimus, 3 milligrams, POBID times 1 week, and then the level and dose to be reassessed. So I'll let you guys think about that for a quick second. What can go wrong with this prescription? So we know tacrolimus is a broad immunosuppressant. Again, this is not purely in an oncology setting. We do see it in transplant patients or bone marrow transplant patients, but we also can see it across a whole spectrum of transplant solid organ patients as well. Okay, so the key takeaway here is to be aware of the long-acting versus the short-acting product. Okay, so Prograf being the short-acting and Advigraf and Varsis being the long-acting product. They are not equivalent. And I know pharmacists know this. The challenge is we see this mistake made frequently. And it's not exclusively, like I said, the pharmacist's mistake. It's the whole kind of system that's leading up to ambiguous prescriptions like this that make it very difficult. So CPOE-based practices do help to kind of rectify some of these challenges. But if you get a prescription like this, it's often helpful if you can't reach the prescriber, which often happens, to to kind of ask the patient a little bit more details about their specific reason that they're taking this. And again, this can be a challenging situation.
So Jason, for people who are not affiliated with hospitals, can you describe what CPOE is about?
Computerized physician order entry. So not most, but many hospital systems would have basically their computer infrastructure where physicians enter electronic prescriptions. They come out, often less ambiguous than some of these examples would be. Thank you, James. So this next one is an example called posaconazole, 300 milligrams POBID, times 2 doses, then 300 milligrams POOD. So this would be a prescription that might come as a supportive or collateral medication, often in a hematology patient for the treatment of or prophylaxis of aspergillosis. Now, what's the important takeaway for pharmacists dispensing this is that this exists in 2 formulations, both a tablet and suspension. So the tablet is the longer acting delayed release formulation, and the suspension is the immediate release formulation. And what's challenging is that the dose is different based on whether it is the tablet or the suspension, but the brand name is the same, so Posanol for both. So if it's not specified and you're not familiar with this, this is a very challenging thing, and this can go wrong. Okay, so check out the monograph, check out Lexicomp or whatever resources you have, and just when you see posaconazole, just do a double check on the dose. So this would be the standard dose for the tablet and not the suspension. And then the last one here in the interest of time. So we mentioned palbociclib earlier. Palbociclib, 100 milligram caps, PO daily times 21 days, then 7 off in a 28-day cycle. So we look at this, and right off the bat, it may not look completely wrong, but this is kind of to show you that just recently palbociclib has changed over from being available as capsules to tablets, and it's actually created a lot of challenges in a frontline practice because if you search for the capsules, you can't find them anymore unless you specifically know to search for this medication as a tablet. So at this point, these capsules no longer exist. Okay, palbociclib has completely moved over to the tablets. So if you get a prescription for a capsule, you can fill it as a tablet. Okay, and if you are interested in these type of safe dispensing practices and want to know really kind of what is the best practice recommendations, Cancer Care Ontario has a very good document. It's called the Take-Home Cancer Drugs Summary, and again, it is completely Googleable. It's about 16 recommendations around the patient's entire take-home cancer journey. And really, pharmacists play a very important role, but there's a lot of important factors that set up situations for errors, including handwritten prescriptions, including the lack of use of computerized physician order entry, including not including the diagnoses for these treatments on the prescriptions or the weight-based dosing. And I know this is a challenge that, hopefully collectively as a profession, we can continue to kind of advocate for the role of the pharmacist in the frontline setting. So last poll here, I'd be very conscious of time, and I thank you guys all very, very much. Was this helpful? You won't hurt my feelings. We've got 2 wonderful sessions coming up. The next is going to be managing opioids in oncology patients with Lauren Hutton, and following that, Megan Hayes will host really kind of an in-depth look on biosimilars in the GCSF space, which is why I kind of cruised over it very quickly. Great.
So I'm seeing a lot of interest in all of the above, Jason, but
awesome. That's great, guys. Thank you. Okay. Perfect. So that's extremely helpful. And again, I know we didn't get a chance to have a lot of discussion in an hour presentation. That's a hard thing to do. But if anybody wants to reach out or chat further, I'm welcome to do so. So again, today's objectives, just to conclude, really just wanted to pick a couple of key emerging areas in oncology practice and go through how you can recognize a toxicity, how you can recognize accessible and reliable references, and a few things that I want you to If you're less familiar with tacrolimus, posaconazole especially, if you see these in your practice, to just kind of do a bit of a double take. Oh, my alarm's going off, so we're at the 1 hour. So the summary here, really, oncology practice and therapeutics evolve quickly. It is hard to stay on top of this, so having a strategy in place to recognize new treatments and things that come in is very, very important. Frontline pharmacists are the most accessible community health provider and often the first point of care for these patients. You do have a lot of resources available. It's just about understanding where to find them. And again, we would welcome the chance to kind of build out a bit of a network of support for all of our kind of whole health colleagues. And Extend Pharmacy, we welcome your thoughts and feedback into how we can help make oncology care in the frontline setting more feasible and help with your confidence in doing so. So session 2 coming up with Lauren on August 26th. This will be an excellent presentation, so I hope everyone here is able to join and share it with your colleagues as well. And then lastly, I thank you all for your attention on this summer evening. Please feel free, questions that I didn't answer, send me an email, or if you'd like, please look me up on LinkedIn. And thank you guys very, very much for your time and attention with this first webinar.
Thank you, Jason. That was great. And I told you those Friday night prescriptions always give me nightmares. So
yeah, totally.
But I think you really provided a good approach for the generalist pharmacist to start to tackle some of these prescriptions that we'll be seeing more and more. There are a few questions.
Sure.
The first one is, where is the recording posted? So it's streamed live onto Facebook, so you'll be able to find it on Whole Health's Facebook page. As well, it's on Whole Health's YouTube channel, and we'll make sure that the recording lives on there for a very long time, so you'll have plenty of opportunity to review it. There are some very specific questions.
Sure.
And they might be too patient-specific for us to answer them, but we'll try. The first one there, Jason, is one patient was getting BCG for bladder cancer, but treatment was not successful, and the cancer spread into the surrounding muscles. What options are available next?
Great question. I'm gonna use the cop-out answer that I had in the poll. More information is needed. Without knowing more about that specific patient, and please do feel free to email me, not patient specifics by any means, but if you want to connect about maybe what some options might be, I'd welcome the chance to chat with you. Options may be, without knowing this patient's history or comorbidities or organ function, platinum-based chemotherapy would not be an uncommon thing, or clinical trial, depending on where the patient lives, and it may or may not involve one of the new immunotherapy options. So without knowing anything more, those would be my broad, slightly cop-out answers. But please feel free to email me if you want to connect and have a chat about that.
Yeah, I think you need to know a little more about the patient to address that.
Yep.
So there's one other question here, and it's in the chat box.
Sure.
So there's a patient complaining of mucositis as well as vaginal pain and ulceration. What would you suggest for vaginal symptoms? And then further down, we have the name of the medications that they're taking. So it's palbociclib, yeah, and exemestane and Falsodex.
Okay. Excellent question. Can you email me that one as well? And I'm pleased to connect with you on that. That's a really good question. So the important takeaway there is mucositis. We most commonly think of mucosa as oral mucosa, but of course it's really the lining of the GI tract and parts of the GU tract as well. So we do not uncommonly see oral mucositis. You have patients that have sore throats, that have, described like swallowing even things like water as kind of pins and needles or knife-like feeling. And of course, it can affect bowel and urinary patterns. The urinary part is a little bit, I think, less obvious than kind of the GI-based or GI tract-based mucositis. And the reason I want to touch base with you is just because there may be a component of menopausal symptoms or induced menopausal symptoms, depending on like when the patient started and things like that. So again, not trying to cop out the answers. I think it's just it needs a little bit more to provide an individualized approach, and I'm pleased to do so. So feel free to email me and I'll connect with you at your convenience.
There's a chat there, Jason, about a practical tip for the use of loratadine for neurogen-related pain. Any experience there?
Yeah, great question. So there are a few formal studies. So when you Google, loratadine or second-generation antihistamines for GCSF pain, you're going to find a ton of support groups and a ton of blogs that kind of advocate for this. It's a great question. There are a few formal studies, one that is kind of suggestive that it does improve pain and another that's kind of suggestive that it doesn't do much. But from our anecdotal experience, when you get in these situations where people are describing bone pain to GCSFs, and if you think of why that happens, GCSFs work to stimulate your bone marrow. So often people will have bone pain, and it's usually in the big hardy bones of the body. So the pelvic crests, usually in the sternum, often in the upper legs and things like that. So it's a very real thing. 30-ish or higher % of people will have bone pain. The good thing is that it goes away when the GCSF stops, and it's related to the dose and duration of the GCSF. So Tylenol is kind of the #1 recommendation, but at the same time, a lot of these patients, if they're taking GCSF, we're worried about the neutrophils going down and masking the fever. So we get this question a lot, like, can we use loratadine? So we always just have a quick kind of interaction check, and I don't think a lot of us, it is something that I have a low threshold to. So I've very commonly suggested to people who have bone pain despite Tylenol or having aches and pains kind of day 2, 3, 4 after GCSF or long-acting Lepelga. So the short answer is yes, I'm quite comfortable with that. We've seen it do nothing for some people, but we've seen it be very beneficial for others, and whether or not, there is a component of a placebo effect there is a valid question. But I think if it's a benign enough thing like loratadine, and the patient has kind of tried sort of the recommended thing, which is usually Tylenol, then yeah, I'm totally okay with giving it a shot. We usually also recommend it not being taken as a PRN, just based on the mechanism of how it supposedly works in bone pain, and that there is a component of histamine release with the GCSF working in the bone marrow. So we would kind of say, yep, like begin, maybe the day of or the day before starting your GCSF if there's no other interactions and things, and see if that works to kind of help prevent the bone pain. Sorry, long-winded answer. So yes, I usually have no problem with that.
That's great, and very interesting discussion to end on, Jason.
Yeah.
I have a great feeling about this series. I think that the first one really opened a lot of our thoughts about how we can approach these patients and prescriptions. And I think that as we move forward with the series, there'll be lots of great learning. So thank you, Jason. Thank you, Extend. And we'll say good night.
Awesome. Thank you, everybody. Take care and have a great rest of the summer.